Thank you very much, Ekene Ndule, for that background. With us in the studios, we would like to welcome Dr. Aliyu Gambo, who is Director General of the National Agency for the Control of AIDS, NACA. Dr. Gambo, pleasure to have you this morning.
Thank you.
Okay. Also here with us is Dr. Omohudu Idogo, who is Managing Director of Society for Family Health. Dr. Idogo, welcome you to the program.
Thank you very much.
Okay. And Dr. Uche Okoro is Program Manager, FCT Agency for the Control of AIDS, FACA. Dr. Okoro, welcome to Good Morning Nigeria.
Thank you.
Okay. Let's begin with the DG of NACA. It's HIV and AIDS still a disease of serious public concern in Nigeria and elsewhere around the world?
Yes. It is still a disease of serious public concern because HIV is not yet under control globally. Transmission is still happening and people are still dying from HIV/AIDS. Until such a time we're able to control HIV within people that have the virus, keeping the virus in the individuals that have it and denying the virus opportunity to leave these individuals and affect other people, and also denying the virus the opportunity to cause sickness in people and cause death. Until we reach that bridge, HIV is still not under control. And that is the bridge the global community is looking at between now to 2030. HIV should be under control, and that control should be sustained.
Obviously, it's not with the same intensity and trend as when it started. So what is the trend at the moment?
Right. So you're right, it's not with the same intensity, and the trend has also changed. And this tremendous shift is taking place because people now have realized that HIV is no longer the disease that kills. HIV can be controlled within individuals, and people that live with the virus can live a healthy life. And in fact, when you see them, you don't see any difference between somebody who carries HIV in his body and those who do not carry HIV in their body because of the medications that are accessible and available, and people are using them. And the use of this medication is changing the entire landscape of HIV globally. And this is what we are advocating. Know your HIV status today if you don't know. And if that status turns out, unfortunately, to be HIV positive, do the needful. And doing the needful is to make sure you access the life-saving medication that are available in all the centers that exist in this country. Failure to know one's HIV status means HIV can still continue to dig havoc in the individual and destroy the individual's defense mechanism. And this is the gateway to the sickness that is seen and also to death.
Okay, thank you, Dr. Gambo. Well, Dr. Omohudu Idogo, time was when every conversation, every forum, every organization, the subject matter for discourse usually HIV and AIDS. There was huge public awareness, but what has happened in terms of either the awareness or the perception of the hazards of HIV and AIDS? That's why I asked the question earlier. Is it still a public threat, or the world, including Nigerians, are just coming down to live with the fact that HIV and AIDS is there? Protect yourself and then you are safe.
Thank you very much. It is very much a public health issue of concern, particularly if you look at the context of where are some of the new infections still coming. So it's still a significant sort of challenge for us as a country in the perspective that infections are higher now in children, in unborn children, what we call sort of mother-to-child transmission or parent-to-child transmission, as we call it. And that makes it pretty significant because every society must set itself to be able to protect its weakest. And if you can't protect your weakest, then clearly that pool is still there. But in addition to children and infants newly born, we have infections still high in different population groups. So we are seeing infections in adolescent and young people, so which is quite critical because, again, if you take it from a socioeconomic perspective, it raises issues that those are the most productive segment of society. And I think I like the point you make, because somehow the beauty of our success, we pray shouldn't become a challenge for us in the future. Because complacency is actually one of the biggest challenge in actually fighting and ensuring that by 2030, we bring HIV under control. The complacency that we fixed the problem, I think, is the messaging out there. But new infections are still happening every day in the country. And one other sort of statistic that I think is important to know is that of the 1.8 million Nigerians who are infected, we have only about 1.6 million on treatment. So there's still a large 200,000 out there who, for various reasons, either don't know their status or are not on treatment. And still clearly the opportunity to transmit still exists. And I think if you add this together, it makes it really important that for a season like this, we re-emphasize the importance that HIV holds for us within the wider public health response that we have as a country.
Okay, Dr. Okoro, you're the program manager for the FCT Agency for Control of AIDS, FACA. Give us an idea of what the trend is within the FCT.
Yes, thank you. There has been a tremendous achievement over the years as regards HIV response. Currently, we are having over 86,000 people living with HIV that are accessing care in our various service points. We also have over 350 points that are providing prevention of mother-to-child transmission in FCT. We also have over 260 sites that are providing life-saving drugs for those 86,000 plus in FCT. Yes, we have made some progress, but in FCT, it's still a concern for us because, yes, we are at the last mile of achieving epidemic control. We are looking for just 7,000 people that are still living with HIV within FCT. And it's become more troublesome, more tasking. How can we be able to identify these 7,000 people? And from our own data, from our own evidence, this also falls down to children. This falls down to adolescents. These are subgroups that are very difficult to reach out. And that is why this year term for World AIDS Day is talking about ending inequalities. How can we now be able to bridge those gaps that are preventing us from achieving HIV epidemic controls? So we are looking at those subpopulations and also looking at what are those strategies that will be better for us to actually use to reach out those population we are targeting at now. So yes, we have done a lot of progress, but as I said, in FCT we are looking for close to 7,000 people that are still yet unidentified. That if we're able to identify that number, we will say yes, we have been able to achieve epidemic control in FCT. So we are happy that the communities are well informed. The facility healthcare workers have been trained. We know where our epidemics are, and we also have the strategy of providing the service. But the problem also here is, of course, is the funding. And again, we're talking about ending inequalities, ending AIDS through sustainable financing. And that is why we're also using the opportunity to also inform FCT residents, please don't give up. Let's continue doing together. We have been doing together, started from the community, religious leaders. Everybody in the FCT have been working hard. So let us continue that tempo to ensure that these 7,000 people that are looking for, we can be able to identify them and also link them to care. And at the same time, while we're identifying the 7,000, we also make sure that the 86,000 are also retained in care, because we cannot be looking for 7,000 and also lose sight of 86,000. So these are where we are in the FCT. And we also want to thank NTA for this opportunity for us to reach out to our FCT residents for the need for everyone to contribute for us to achieve that unmet needs of 7,000 people that we're looking for.
Thank you, Dr. Okoro. Dr. Gambo, DG Naka, let's come back again. Time was when there was some celebration about achievements in reducing drastically mother-to-child transmission of HIV and AIDS. But we are hearing now that perhaps the new numbers are coming up amongst children and then amongst, of course, the adolescent groups. What accounts for this?
Right. So there are three major running tabs that must close before HIV epidemic will be under control. And these three tabs are: one, the general public, and two, key affected population, and the third one is mother-to-child transmission. On the general public, I have heard the statistics you've called earlier, that things have changed from 5.8% in 2001 to now 1.3% in 2021. And what has happened in between was that before, the data we're using are not complete data like the one we have had very recently. And because of that, for you to be able to know who has the virus and who doesn't have in a country like Nigeria, the ideal thing is to do a census. Get everyone, test everyone, and then find out who actually has and who doesn't have. So, but resources don't usually allow, and is not even encouraged to do everyone. What we do scientifically is we take a sample. And there was not a time we take a population level sample like the ones we have done 2-3 years back. So the ones we've done 2-3 years back give us the real picture of what has been occurring in terms of the impact that the treatment program we have had in place and the prevention program has had, and the gaps, the unmet needs. So after that, we now realize that mother-to-child transmission is one of the areas that we have not been doing very well. For key affected population, I know Dr. Mokadu, who has been working in that area, will testify that the one-stop shop that we provide in service, or we are enabling those individuals to access services, have increased. In fact, from what it was like a 10 one-stop shop in 2 years back or so, now we are talking of about more than 100 where those services are accessed nationwide. And recently we've discussed how that has changed the way we identify people living with HIV/AIDS from among us. An example, when I came on board 2019, one thing that I requested was that we want to see the number of people that have been on treatment, that we have identified. We want to see their names, we want to see the data the way it is. And what we had then was about between 800 to 900,000 individuals as of 2019. Today, as I'm talking to you, we have 1.6 million on treatment that we can count. And we have 200,000 more to go. So these inequalities that we're talking about are largely in these areas, like the mother-to-child transmission. And the problem here is not that the mother-to-child transmission program is not working. It's working. But access to the population is the one that is difficult. We stay at the facility and we wait until the mothers come for antenatal care to give them these services. What we are doing now is we're reaching out. We are going to the community. We are going to places where mothers feel comfortable to access antenatal services. Some of them access antenatal services at religious places of worship. Some of them at community centers. Some of them are happy to access it at marketplace. And some of them at the comfort of their rooms. So if they are likely comfortable to access HIV services at these areas, at the comfort of their rooms, and we give them HIV self-test. They can test themselves and know whenever they are pregnant, that pregnant deserve to be tested for HIV. And the unborn baby has right to be protected from HIV. If mothers and fathers understand this message, and they understand the need to test every pregnancy, whether they show up for antenatal or they don't show up for antenatal, they stay and the delivery is taken by traditional birth attendants at home. That pregnancy is tested for HIV. That will now help us to count for every pregnant woman and count for every risk of mother-to-child transmission. But until we get that cooperation and until we have that access to every pregnant woman, mother-to-child transmission will still continue to elude us. And is the most painful thing if you want to end HIV, because you're giving HIV to a generation that is just starting their life. Somebody that is born today has the next 50 years, 70 years, or even 80 years to live probably. And that individual carrying HIV, that shows how long we will continue to haggle or to struggle with HIV before we say HIV is ended. So that is one area now that we are focusing as a nation and as program, mother-to-child transmission, to show that change within the next 1 year. If we are able to do that, Nigeria is at the verge of controlling HIV in the next 18 months.
Adolescent population.
Right. So adolescent population is also another population group that has been very, very difficult and challenging to deal with, in the sense that what connects to the general public doesn't usually connect to these individuals. The program we do right now is not usually the program they like to see, or it's not the program usually that reaches out to them. So we had to figure out ways to connect with them. And these are the social media individuals, where you need to find out their networks, you need to find out their groups, you need to find out what they like to hear, and use these vehicles to reach out to them. We have started since 2 years, I think, when we met in Kigali. And they were there represented and they expressed themselves clearly. What they said was that we got to know that nothing for them without them. But I told them, yes, I had you. Nothing for you without you. So now going forward, whatever we are preparing or we are putting together as program, we'll definitely have you represented there. And we will listen to you, and we will use whatever mechanism you feel comfortable, to reach out to your folks and networks. And that we're doing.
All right, let me take my question to Dr. Idoho, I beg your pardon. In the past, at the outset, the messaging was quite critical, and it was know your status. It was intensive, and that was how we're able to achieve the mark, and even meet some of the MDG goals in terms of HIV and AIDS eradication. So now that we're having new cases among the children, mother-to-child transmission and adult, what is the messaging? Has it changed from what it used to be?
Thank you. The messaging in terms of the broad intent hasn't changed, but I think the medium, the channels, the nuance have changed. I think, for example, at a sort of broad policy conversation level, I often say that we shouldn't be saying we have 1.6 million people on treatment. The conversation should now be, where are the 200,000 that are not on treatment? So it's the same message, but flipped slightly differently. Because putting that question that way in terms of who is being left behind is going to then therefore highlight the where we need to make and put our focus as a country. Knowing one's status is still very much at the core of the first 95. That's the first step to epidemic control. And so that message is still very critical, and I think the media has a big role to put that out there. But I think the understanding those who are actually being left behind on that testing shapes the way and where we deliver that. So for example, on PMTCT, or mother-to-child transmission, or parent-to-child transmission, to correct myself as we put it, because I think the roles of father is really critical. And I think maybe that was one of the first conversations, just maybe coming to the point you raised. Maybe we need to emphasize more of parent to child rather than mother, because I think the roles of fathers is so central. I was in a conversation, I think 2 days ago, and I remember somebody vividly saying there's a lot of focus on mentor mother. We should also start focusing on mentor fathers, the role that fathers have in terms of the health care of their homes, of their families, of their wife. So being able to get that message, for example, to that traditional bent attendant or whatever point that the woman or that the family feels more comfortable to have their children is going to be central. When it comes to adolescents, same messaging, but what channel do we use? Of course, they are more into digital media, social media as put out there, radio, music programs. So I think there's a role there. But I think sort of reflecting broadly, I would say for a lot of us, including media, including sort of traditional religious institution, we've sort of removed our leg a bit off the throttle. And I think this is the time to actually put that leg back on the throttle, because the last mile is always the most difficult mile. And I think one of the big mistakes we'll make as a country, as a people, is to think we finished the problem when the problem hasn't been dealt with. Because what you're then going to get, like Dr. Gambo talked about, you create a whole generation where in the next 50, 60 years, we'll continue to see infections until we're able to so the message remains very clear. You must know your HIV status. The message is also very clear that the quality of care, the quality of treatment today is very, very good. It's deep, very top quality, and that you could live and live very well with HIV. The message should be everything that removes stigma, that reduces discrimination, and the message should be a strong focus on ensuring that we look at what are the barriers that are still limiting some population groups from accessing services. For example, key populations. So that's like a whole group we are looking at, focusing very strongly on them, creating the enabling environment, and also sort of what I call engineering the service delivery architecture to better deliver services to them. Dr. Gambo talked about the one-stop shop. For example, as Society for Family Health, that's one thing we do. As a country, we have close to 116 of those now. That's one shop stop that actually gives you a whole range of services that covers both HIV, you're talking STI treatment, and the whole full spectrum. And so those are very critical. And I think maybe a final word on messaging. I think adherence is also a message I think we really would want the media and everybody to put out there. If you look at the cascade, the third cascade, which is virally suppressed, is still 86%. So that's the lowest. So we need to put a message out there that even for those on treatment, it's so vital that we take those medicine at regular, as prescribed by our doctors and our healthcare professional, and everything to keep us sort of well and safe. So that's a message I think can be added to the bundle in terms of sort of preaching the message of adherence and more sort of broad health-seeking behavior.
Well, thank you, Dr. Idogo. I mean, this question, anyone can take it up. I was just wondering, have you had the opportunity of taking a step back and then attempting an evaluation of the impact of other existential threats to the effectiveness of the message and messaging on HIV and AIDS? I mean, we're almost 2 years now into the COVID-19 pandemic, and that is the message that is all over the world. And then for our own local circumstance, you also have very rapid killers amongst us. A person will be more frightened of bandits and kidnappers than probably will be frightened of HIV and AIDS. I mean, precautions are taken. But when you are faced with a broad range of immediate concerns, where does the message of HIV sink in, and how does that then affect your behavior? Have you had time to evaluate this, Dr. Gambo?
All right. So what you're saying is some of the what we say precipitous of HIV infection, because HIV is a social developmental disease. It's not only health issue, but it's an economic issue. It's a security issue. When there are conflicts, when there are instabilities, HIV breeds. And that is why we're looking at this time at the time to intensify the messaging in terms of HIV. It will certainly affect the trajectory. It will certainly breed new infection. It will certainly put many people, more people at risk of acquiring HIV, because there are risky behaviors that happen, you know, whenever you have insecurity, whenever you have insurgency, you have IDPs, which have been existing for some time and for which we have been visiting and we have been providing services. We're seeing what has been happening there. You see cases of new infection. You see cases of what Dr. Makado is talking about, lack of adherence to medication because of this instability. Access to where the medications have been provided, you know, have been destabilized. People have been dislodged from where they are, so now they are thinking of where to stay to be safe, not where to even access the medication. So certainly these are factors that no doubt will play a critical role, you know, in changing the dynamics in terms of increasing the rate of new infection and in terms of lacking adherence to treatment, because in those areas, access to treatment will now be denied. But that said, on the other hand, the number that we want to hold on to are the numbers that we have in our kitty, those ones that we sure that we have identified, we sure that we've started them on treatment and we maintain them on treatment. We will want to make sure that access to the medication, with the exception of those areas where there are no access, you know, continues, and people take this medication, because it is only when you take this medication that we will be able to achieve control within individuals. And once we achieve that control within individuals, it means we will achieve control as a whole. Denying the virus opportunity to live where it is and keeping the virus where it is and making sure that it doesn't show in the individual blood. When you test, you don't see it, it disappears. Once it is not detectable, it is not transmittable. And that is what we are focusing on. But certainly those are factors: poverty, insecurity, conflicts. They all affect the trajectories of HIV prevalence, new infection, and access to services, as well as adherence to those services.
Thank you, Dr. Gamble. Let's bring in Dr. Okoro. Dr. Okoro, we know that women accessing antenatal care in the hospitals, still the safest place to identify or detect or for women to know their HIV and AIDS status. But Dr. Gambo had talked about taking access, you know, to a more comfortable place, either to the places of worship, to you know, where the women would prefer. But do you think that that would halt stigmatization and discrimination, which is still in existence? I mean, we can't deny that fact. Do you think that we can take the safe area to reach these pregnant women out of the hospital, out of the medical healthcare centers, you know, to their places of comfort? Is that a strategy that you would recommend?
Yes, we have been doing that. That's why I said in my opening remarks that in FCT we have over 350 sites that are providing prevention of parents to mother-child transmission. And
safe sites.
Safe sites, yes, safe sites.
And please also let us know what you mean by safe.
Safe site is that we have healthcare personnel that have been trained to take delivery, to do HIV tests, to also provide antiretroviral drugs for the mothers that are positive, to also provide early infant diagnosis for children that are exposed, children that are born of mothers that are HIV positive. These are what I mean by safe centers. And these are personnel we have trained over the years. We have the strategy. They are there. What we want now is how can we collectively encourage in your community where you notice that a woman is pregnant. It is our duty to say, Madam, have you gone to register in the closest? Because these centers are very close. It's a walking distance. Be it traditional birth attendants, we also train them. We have all of them in our records. We visit them, give them training. If you identify any pregnant woman that is positive in your center, please refer to the closest center.
Why is it difficult to mainstream this strategy, these services you're providing now, into the antenatal care, such that the positive mothers don't have to, take extra, have extra burden leaving the health centers. It's such that they can access both the HIV/AIDS care as well as their antenatal services in one spot.
Yes, they are integrated.
Okay, they are integrated.
Yes.
Within the healthcare center.
Yes, all HIV services are integrated within other services in the hospitals. So our services are integrated because it is the same healthcare worker that provide services for other disease conditions. So they're integrated. So they are there. But you cannot, it is everybody's right to decide where to go and access care. And that is why what we are doing now is to ensure that whether it is religious hospital that they want to deliver, we have trained the healthcare workers there. Whether it's a traditional birth attendants that they want to deliver, we have also trained them to be able to identify, because the first step is to know your status. When you know your status through HIV test, then other services can be provided. Of course, we know that actually, because of the economic downturn on our people, some of those pregnant women will also find a difficulty in going to to healthcare services in their closest, with the fear that if I go there, I'm going to pay. But these services are free. So we are now using the community gatekeeper to reach out to the pregnant women in the community. Look, these services are here, very close to you, and they are free. So there's no point to be afraid of. Say I'm afraid of if I go there, it will charge me. We're also engaging religious leaders. We go to church, we go to mosque to provide sanitation to pregnant women. Say, look, these services are within your community. They are free. You don't need to pay anything. Just, it's a walking distance. And that is why we scale up the services. So you don't need to come to the center, come to Wuse, come to Maitama. No. They are all over the places in our primary care centers where staff have been trained on how to provide those services. So we are doing it. That's why I'm saying it is a collective effort. The community leaders, everybody in Nigeria, in FCT, tell your neighbor, tell your sister who is pregnant, please, where are you doing your antenatal? It's our duty to remind them that, look, these services are free. Not just to stay at home and say, they will charge me. No, it is free. Free.
All right, thank you, Dr. Okoro. I just wondered, is stigmatization still an impediment to the realization of the measures aimed at curtailing the spread of HIV and AIDS? Dr. Edowu.
Yeah, thank you. Stigmatization still remains a big issue, and it plays at different level and affects different groups differently. So, for example, we've been talking about PMTCT. The interesting thing on the question you raised is really that if you look at our statistic, even devoid of HIV, the general sort of health statistic, the number of women that actually attend antenatal as a country, it's about 6 in 10. So basically about 60 something percent. And if you then look at delivery on that scale, it's even lower, and it varies state by state. So which was the point Dr. Gambo alluded to initially, that our response all along has been very focused on sort of using the healthcare infrastructure But the vast number of our women, 4 out of 10 literally, will not even deliver there. Some will even attend antenatal, you'll be surprised, but they prefer to deliver in their religious leaders' small sort of health arrangement. So, and I think the conversation now is we've taken the service there. So we're no longer waiting. So there are stigma that tie to that. Some of the stigma, for example, are broad, even broader than the HIV. So for example, you hear conversation in family about the safest place to deliver. So that clearly plays a role in where that woman would have that baby. But leaving PMTCT, of course, groups like key population, there's a lot of stigma within that group, a lot of discrimination within that group. And that's really the basis where the idea of one-stop shop, that's like a safe space where they actually can sort of engage the healthcare system and get a comprehensive array of services delivered to them. So still major issue. For adolescent and young people, stigma is still there. Stigma in terms of even accessing the services, the protective services they need, in terms of being able to interface with the healthcare infrastructure and say, okay, we need this for our good. So stigma still remains an issue. Discrimination is an issue across the different levels. But I think the good news is it's clearly not as bad as it was if you were to look back at, say, 2014. But the journey is still clearly on the road. I think a lot still needs to be done to actually make that sort of big difference that actually allow people to engage the service delivery opportunity out there. And the real theme of the world, if you look at it, is the inequality. Inequality is not about small pockets of people, depending on their different contexts and why they are therefore not able to access services, and it varies. We've talked about some of those groups, but it's also something about geographies also. And so these are where we really need to push the message to manage and sort of ensure that we're on course for epidemic control.
You just took out the inequality aspect of it, from my mouth, because I was wondering how does inequality play out in terms of accessing HIV and AIDS care?
In different ways. So, for example, if you look at, for many years, even the conversation around HIV saw it very much as their gender constructs that actually increase risk for certain gender groups. So if you look at the woman has a higher risk overall, partly constructed by the patriarchal, the way society is structured, how she's able to express herself or not express herself, how she's, for example, able to access service or not access service. And those are still factors that play in the conversation around inequality. So if you look at, for example, the 200,000 as a country we are looking out for now, who are those people? You see that the vast number of those people will be women. We've talked about children. So, for example, if you look at the numbers for children, we know there's about 150,000. We have about, give or take, about 60 or thereabout on treatment. So there's about 90,000 of children we don't know. So that gives you a sense. So women, children, key population groups, partly because, again, very stigmatized groups. So there are inequalities within these groups. And I think that's really where, and the clarion call for action for this World AIDS Day.
Dr. Gambo, is there a dichotomy still between rural and urban populations with regard to the prevalence of HIV and AIDS, ability to access treatment, ability to even know your status? Is there a dichotomy? And if there is, how is it being breached?
Yes, there is dichotomy in the sense that HIV awareness and access to HIV services are more in the urban population than in the rural population. And the HIV itself, in terms of the way we find cases and the way we manage them, are more in the urban than in the rural. So you can say that this breeds more in the urban than in the rural. But that said, we have now decentralized our services in the sense that we don't stick to only urban centers. We also have services in the rural centers. And we have volunteers that are trained that are not only limited to urban population, but they are also found in rural population. And because of that, and the addition is the awareness campaign that is all over the place. The media, the radio, television, and social media now, access to information has changed the trajectory in the sense that in the past, we have less awareness in the rural areas and we have less access to that population. Now we have more access to the population than we have had in the past. But the only rate limiting step now, the insecurity in some part of the country where the rural population are largely more involved or affected than the urban population. So whatever centers we have in those locations are now either not functioning or they are functioning but not fully. And it's understandable because of the situations that exist. But in terms of widening our accesses, we have widened our access. We have more implementing partners now than we have in the past, and they cover now more areas than they cover in the past. So yes, we are bridging these inequalities, and we are seeing gains in them. However, the gains we are seeing are not unaffected by the present reality of what is happening, especially the security situations in those areas.
Talking about partnerships, let's also look at commitments, because that's one key strategy, that is driving the 2030 goals, if we are indeed to ensure that no one is left behind. And with regards to HIV and AIDS eradication or halting, spread of HIV and AIDS, it would appear that the force is really coming from the national level. At the subnational level, there seems to be this quietening complacency, even with budgeting for HIV and AIDS course. What's your view about that? What's the vibes that you are getting?
We cannot control and sustain the control of HIV without involvement of the state. Without states taking ownership of HIV program and driving them, there won't be that kind of speedy progress in terms of getting the virus under control and making sure that the virus is kept under total control. Let me give you an example. 90% of the facilities where HIV services are given nationally belong to states. 90% of patients that are treated for HIV nationally belong to states. And 90%, or almost 90% of human resources for health that provide services for HIV nationwide belong to states. And 90% of the resources that are used in fighting HIV do not come from the state. So you see the discrepancy here. And until we get the states to invest, and until the state realize that they have this responsibility, to own their program and making sure that people that are receiving services at the facilities that they own include people receiving services for HIV and they are citizens of the state. And the state has a role to contribute. Even if we get HIV under control, we may struggle to sustain that control for a long time to come. And because of that, the private sector has seen a kind of a niche here to come bridge. This is what we're working on for the past 2 years to get the private sector to come in and do similar things we have seen with COVID-19, which is the COVID, which means private sector getting resources together and assisting the national response. The assistance we're looking at here is providing medication and providing kits and reagents and providing the logistics to move these medications, kits and reagents, to various places. If we do that and we got continuous commitment from our heavy lifters, United States of America and the Global Fund, even though we know by the time the epidemic is under control, the amount of money that is made available for this response will definitely come down and will shrink. With what the federal government is doing now and these other stakeholders, what we are appealing to the states to do is just keep the clinic going. Keep the clinic going, pay the health workers that provide these services, provide somebody like Dr. Okoro the logistics. Let him have the necessary vehicles to move around, to coordinate, to identify the 7,000 and making sure that the people that work under Dr. Okoro are paid. We are not asking the state to give us medication. We are not asking the state at this stage to give us kits. We are not asking them to contribute reagents. No, keep the clinic going. Pay salary of staff that run the clinic.
Are they doing that?
So,
are they doing that against the backdrop of what we know to be the state of primary health care centers across the country?
the states are keeping the clinic for now. And the additional thing we want the state to do is provide the coordination mechanism, provide the resources. Let Dr. Okoro has vehicles to move around. Let Dr. Okoro has wherewithal to collect data and transmit data nationally to where data now should be collected, collated, and seen as nationally representative, that are coming from the states, and they are owned by the states, and the state validate this data and say, these data are coming from us, and they are real. This is the number of people we have now on treatment, and as of the month that has passed, these are the number that have been added on treatment. So this is what we are looking forward from the state, and we hope, within the next 2 years, with what we are doing now in Abia and Taraba, the model we are putting in place, we will reach that stage where we clearly define the divided lines, where we want the state to come, what we want them to do exactly, and where the federal government, private sector, and global donors will come.
All right, I was talking about primary health care centers and the role of PHCs in all of this. Again, we know the parlous state of the primary health care centers. What evidence do we have about the enthusiasm of states and local governments in these activities? Years ago, I'm sure if you went around most state capitals, you will see the signboard of, if not billboards, of the State Committee on AIDS. It's really called SACA. Billboard signs SACA all over the place. But I doubt if you will find that in most state capitals today.
Yeah, thank you for that. I think as a country, we're on a journey, and I think that journey, it's a journey of continuous improvements. I think clearly the conversation around primary health care, the whole primary health care system, our broader health sort of infrastructure, it's been on for a long time. But I think there are some positive for any onlooker. For example, looking at what we're able to achieve with COVID, the speed in which we're able to ramp up laboratories from less than even 10 initially to more than where we are now, 100 across. So I think there are real opportunities, and I think those dynamics are there. But that said, I think clearly every sort of observer knows that our PSC system continue to struggle, but it does vary state by state. Some states more progressive than others. And I think what has happened within the sort of HIV response is really that some centers, of course, were prioritized. Investment is being made in those centers. And to a large extent, those centers are functioning pretty well, very, very well. And I think, like Dr. Gambo has talked about, the conversation ongoing now and over the next 2 years is to come to some sort of very sort of strong partnership with states so that the role of the centra is very clear, maybe around procurement, medicines, consumables, and all, maybe medicines, diagnostics, why state take on roles like he described around human resource in those centers, management of those centers, program coordination in their states. And I think I feel positive that those are trajectories that would be achieved even as we push forward. in the next couple of 2-3 years, even on that journey. Yeah.
All right, Dr. Idogo, just a good point for us to take a short break and take some commercials. When we come back, we'll just continue with the end part of our conversation. Don't go away.
19, that is the black swan of the century, has actually hit the whole world very hard, even the strongest of economies, and Nigeria was not spared. But due to the proactive stance and steps that the president has taken, we've been able to come out quickly. The president has consistently said we must invest in infrastructure, even as we're investing in human capital, that we must invest in infrastructure, because at the end of the day, that is what will bring about a sustainable economic growth. So the president has given us our directive. He has said you must make sure you pay salaries and pay pensions, but you also make sure that the critical projects of roads, railway, airports, bridges, major infrastructure that are meant to drive the growth of the economy, that we consistently invest in them, even if we have to continue to borrow to do so.
This message is from the Federal Ministry of Information and Culture.
Finally, the hero of Nigeria's democracy has arrived. He shall usher us into a new phase of development, peace, and prosperity. He is the father of the new Nigeria, His Excellency President Muhammadu Buhari, GCFR. Welcome to another season of giving Nigerians hope yet again. We are sure of a great future for both ourselves and generations yet unborn. We look forward to your leading us as a nation into our manifest destiny. Though the challenges against us as a people are many, we know that your leadership shall set us on the right path to our greatness. A new dawn beckons on us all, and having you as our president is a precursor to this. Thank you for believing in Nigeria.
All right, welcome back. You're watching Good Morning Nigeria live on the network service, and our conversation is on how to rethink our strategy to eliminate HIV and AIDS by 2030. We still have all our guests here in the studio, and that's why I'd like to take my question to Dr. Okoro, who is looking for 7,000 people, trying to identify the 7,000 people in the FCT who are down with the virus. Dr. Okoro, how do you hope to do that? Any innovative, creative way of...
Yes, because we have known where those 7,000 can be found. It should be among the adolescents, people. It's going to be among the key populations. Of course, it's going to be among the pregnant women that are HIV positive. So our strategy now is we are narrowing, targeting at these subpopulations. Vis-a-vis with the little resources we have now, we want to see how we can channel our interventions, targeting at these subpopulations, so that we can get results to be able to find these 7,000 people that we are looking for. And also, at the same time, ensuring that the 86,000 that are already in our facility receiving the life-saving drugs are also returned and continuously also having virus suppressed. So we have known where they are. We are looking at our strategy, which are going to be more specific this time around on directing our interventions towards adolescents and young people. Key population, we continue. We are doing so much in key population, but we still want to do more to ensure that more of members of that subpopulation are also linked to services, identify those who are positive, and then link them to care. Pregnant women, yes, we are still also focusing on them, ensuring that in the communities, traditional birth attendants, religious bodies that are providing deliveries, we engage them and also build their capacity.
Did I hear you earlier say that accessing the treatment drugs is free?
It's free, totally free.
Okay. What about the drugs itself?
Everything about it is free.
It's free?
It's free. Test
no
is
hidden
free.
charges?
No hidden charges. As long as HIV services is concerned, it's free. When we have challenges, maybe, of course, when we come to cats, which that one, cat is not free. you have to pay for cat. But what we are doing now is to ensure that all pregnant women who are coming to access care in these services, we're having discussion with the administrators of these healthcare facilities to give a waiver to all the pregnant women who are coming to access care, not to charge them on card. So that's what we are having those conversation with them, so that all the services will be free. Not only that, we're also going to see, because not all the pregnant women that are poor, we are also going to try to look at those ones that are the poorest among them, and also see how can we provide some stipend in terms of transportation, going. Because this is also what we have done in the past. And it helps of...
I hope Dr. Okoro is not just saying this.
No, we have done in the past.
It's
a practical
strategy that can be implemented.
When World Bank was supporting us, this is what we did in the past. And that's why it has taken us to this level. We're able to provide those stipends to them, to the pregnant women. We did it in conjunction with the health facilities. Okay, fine. Mothers, if you deliver in this facility, you are going to have this amount of money.
You know why I asked that question?
Yes, we did it.
You just said now, with the meager resources.
Yes.
So I'm wondering where you're going to have the money, you know.
That's why I'm saying that not all pregnant women that are poor. We are now going to work with the health facility to be able to identify those poor women that are pregnant who cannot be able to afford going to that center. How can we assist them? Because until we do that, they will not be able to come. Talk more of delivering. So we are going to engage. That resource we are going to have, we are going to use it judiciously and targeting on those pregnant women that are poor who cannot be able to pay transport money. So that's what we did in the past, and it gave us good results. Okay. So those are one of the strategies we are going to use.
Okay, Dr. Idogo, what is the role, if any, these days, of opportunistic ailments in the effective management of HIV and AIDS? I mean, in the earlier years, we used to hear that TB would be an accelerator of fatality arising from HIV and AIDS. How are these, if you like, comorbidities being tackled along with HIV and AIDS these days?
Opportunistic infection remains an issue for the HIV community. So it's clearly something we look out for. So for example, one of the national push we also have is looking at sort of what we call TB, HIV co-infection. So that's a big part even of the program. A whole attempt that every single client who tests positive for TB or even has indicative from our screening that may be TB positive also gets a HIV test. So that's clearly something, and that's been yielding some significant numbers on both sides. And I think even on the HIV side, again, a strong encouragement and part of the program to also push for TB testing within the HIV positive community. And that has yielded numbers. Like if you look at what we're able to achieve as a country last year, it's actually amazing, both on the HIV side. So for example, adding almost close to 300,000 people on treatment just at the heart of even COVID in 2020. I think it's an amazing feat that I think as a country we all need to celebrate. In the same way, we also added significant numbers on the TB side, so that for the first time, we actually had the highest, at least for the longest time, in terms of notification, TB notification. So that's like one clear comorbidity. The other sort of broader spectrum around that, that's why the one-stop shop is such a sort of cost strategy in terms of how we approach key population and service delivery, because that looks again at a number of things, including sexually transmitted infections, which we also know tends to accelerate HIV infection, and also the wider spectrum. So it's almost a full 360-degree view, and in terms of still looking at opportunistic infection, prioritizing them, and also not just in terms of a HIV response, but also from those opportunistic infection to HIV also. So almost like a bi-directional travel. That's really the heart of the programs that we're running.
What do we know about the fatalities? Do we have any per annum fatalities traceable directly to HIV and AIDS in Nigeria so over the past 3-4 years?
Yes, we do. But I think Dr. Gambo,
Dr.
you want
Gambo,
to-
what are the numbers?
I don't have the numbers off head now that I can give in terms of how many people that have HIV probably die because of opportunistic complication of opportunistic infection, especially tuberculosis. Tuberculosis is the main killer when it comes to people living with HIV/AIDS, that have opportunistic infection, and also vice versa, as Dr. Omakadu has said. They go hand in hand. TB and HIV. Yeah.
I'm looking at the role of traditional medicine, because whether we like it or not, a lot of people still believe that traditional medicine, the use of herbs and all those concoctions, still cure HIV and AIDS. Is there a plan? Do you have plans or such initiative to really look at research, our traditional medicines, the propensity of that to cure or even treat HIV and AIDS? Are there plans to research traditional medicine in this regard?
As a nation, we're very happy to see products that may be generated here locally and are used to cure diseases, including HIV if they exist, and probably have the potentials of being used globally. One area we have issues, when people make claims, what we say is we want to subject it to the scientific process. And that's where we have issues with claimants of all this medication, either traditional medication or a cure for HIV. In the past, we have struggled with that. And now we don't see them much as we have seen them before. But what we're saying is that our doors are open. There are regulatory agencies in the country that when you make claim, they subject your claim to a process. And once they subject your claim to a process, and if that process is found to be valid and the claim found to be useful, they will let us know. Part of what we do is to use the medication to cure HIV. We don't generate the medication and we don't take part in producing this medication. So if somebody today claims that they have a product and that product is found to be effective with people living with HIV/AIDS, probably they have tried it on some people and they have seen some success. You come to us, we say, yes, welcome. And it's something that we'll be happy to look at, and it's something that we'll be happy to subject to the process, scientific process.
Okay.
Yeah.
I was going to ask if you have received such proposals. Has any of our traditional medicine dealers, approached the agency?
For the 2.5 years that I have been at the helm of NACA, I haven't seen that. I have received. But I have had claimants in the past before I assumed office. And even after I assumed office, there was a resurgence of such claim. Somebody was coming out to say, his vaccine or whatever was not allowed to prosper because people just don't want to let people progress. And which I replied, and then the person has some posting in social media, and I had to create a rebuttal to say no. We welcome scientific development, and whatever product people have, we're ready to have a discussion. But they should also be ready to subject it to scientific process. If you have a product and you are afraid of subjecting it to scientific process and you don't want others to look at it and give you their verdict, then probably you're not sure of what you're claiming.
Well, what we saw from last year and still ongoing is that medical researchers around the world put on their thinking caps, funding came, and within a short time, we had a number of vaccines available for COVID-19. HIV and AIDS came onto the global scene 40 years ago, and we still don't have a vaccine. What is happening? Is there some politics? Is there some medical politics around this, or what?
I think the scientific process continues to evolve. I think maybe just a quick comment on the speed of the COVID vaccine. One of the things I think we should all understand is the COVID vaccine was built literally on what I would say an existing infrastructure that has been developed over the last 20 years. So it wasn't necessarily from scratch. So I think it's really important because those comments are, oh, well, we're able to do this within such a short time. Both the delivery mechanism itself has been a whole scientific process that if you look, it's taken almost 13 years to perfect. The way the vaccine itself, the molecule was designed, again, that's been as long as we've had the smallpox, in terms of how you modify. So I think that's what science brought together very quickly to actually deliver.
Vaccine research has been going on also for decades.
Yeah. Well, coming to the AIDS vaccine, the HIV virus by its very nature is very unique. I think that's the first thing to say. Very different from the SARS group of virus, which had been thoroughly studied. Because in some of the sort of Western European climes, they have influenza vaccines, they have their normal sort of flu vaccines, jab, which they take yearly. So that was how it was built. But let's come to the subject matter. The HIV vaccine, I think, is in an accelerated phase now. I know there are about 4 candidates that are being discussed. So that's clearly in some way playing out. But that's not to say, of course, there's always politics and some consideration in how this works. If you were to look at, for example, the COVID was basically a global pandemic, right from the way it is. Why the HIV virus took a slightly different, of course, still global in every sense of that word, but took a slightly different course. But I think it's really important we celebrate the success that has also been achieved in HIV, that we don't mix the point. If you look at the quality of medicines that we have today in the whole sort of what I call antiviral space, the HIV sort of epidemic has supported those developments. If I look back in 2000...
Your last sentence, please.
I think the last sentence here, just to say that we are really at a very exciting point as a country. And I think really we must all pull together to say where are the 200,000 people that we are sort of missing out now. And let's all work together, both the media, very central role here, for us to actually find these 200,000 people, put them on treatment, and actually as a country move towards epidemic control, even before 2030.
All right, Dr. Omohudu Idowu, thank you very much. Managing Director, Society for Family Health, SFH. Let me also appreciate Dr. Uche Okoro, Program Manager, FCT Agency for the Control of AIDS, FACA, and the Director General, National Agency for the Control of AIDS, NACA, Dr. Aliyu Gambo. Thank you very much, gentlemen, for coming to share your perspectives with us on Good Morning.